So President Trump has just dropped his great healthcare plan, and it is built on some absolutely huge promises. But behind all the slogans, what's actually being proposed? In this explainer, we're going to cut through the noise, look at the official plan, and see what policy experts are saying to really figure out what this could all mean for American healthcare.
Okay, so this is the big one. The headline promise. The goal is to slash the prices we pay for our prescriptions, taking the US from the most expensive country in the world to the cheapest. I mean, that is an incredibly ambitious claim, right? So how exactly does the plan propose to make that happen? Let's dig in. All right, the whole plan really rests on these 4 core pillars. Each one is a huge piece of the puzzle, so we're going to walk through them one by one to see what's really inside and what the potential ripple effects could be.
So, how does the plan promise to deliver the lowest drug prices in the world? Well, the key is an idea called most favored nation pricing.
The concept here is actually pretty simple on the surface. The US government would basically look at what other similar developed countries pay for a drug, find the absolute lowest price, and then declare that's the new maximum price here. No more, no less. But here's the thing, this idea isn't exactly new, and as this timeline shows, it has let's call it a complicated past. A previous attempt to even test this was blocked by the courts over procedural stuff. This new plan wants to bring it back, but not as a test, as the law of the land. And that complicated history brings up some massive legal questions. Policy analysts are pointing out that the proposal is really thin on crucial details. For instance, would this only apply to government plans like Medicare, or would it affect your private insurance too? And how on earth would it work with the drug price negotiation law that already exists? Right now, those details are just missing. All right, let's shift gears to the second pillar. And this one proposes a pretty radical shift in how the government handles insurance subsidies. So you've got 2 big ideas here. First, instead of the government sending subsidy payments to the big insurance companies, that money would go directly to you. Second, it proposes to fully fund something called cost-sharing reductions, or CSRs, which are payments designed to lower your deductibles and other out-of-pocket costs. The argument for these direct payments is framed as a big win for consumers. The idea is to cut out the insurance company as a middleman, right? Give people cash directly so they can shop for the plan they actually want, creating more competition and giving them more control.
But as you can imagine, policy analysts immediately have a name for this. They call it a voucher model. And that term is really important because it's not just jargon. It signals a long-running debate and carries a very specific set of warnings about what could happen to the insurance market if you do it.
So here is the core concern, the big worry. What if you could use this money to buy any plan, even a cheap one that doesn't cover pre-existing conditions? Experts warn that healthier people might grab those cheaper, less comprehensive plans. And if they do, that leaves only sicker, more expensive patients in the main insurance pool. When that happens, premiums for everyone left behind can absolutely skyrocket, creating what analysts call an insurance death spiral. Now, the other part of this proposal is funding those CSRs, and this is where things get really strange. It is a complete 180 because the Trump administration is the one that stopped these exact payments back in 2017. To understand why bringing them back is so controversial, we have to look at the completely unexpected chain reaction that first decision set off. Okay, stay with me on this one. When those government payments stopped, insurers still had to give the discounts by law. So states came up with this clever, if a little complicated, workaround called silver loading. They basically told insurers to bake all those extra costs into the sticker price of just one type of plan, the silver plans, which made them look artificially expensive. And here is the wild, unintended consequence. Government subsidies are calculated based on the price of those very same silver plans. So when silver loading made the silver plans look more expensive, the government subsidies got bigger for everyone. The paradox is that many people ended up paying less for their insurance. So restoring the old payments would reverse all of this and could ironically cause net premiums to go up for millions of people. Okay, moving on to pillar number 3. The plan pushes hard on transparency. The core idea is to force hospitals and insurance companies to finally reveal their real prices. The plan details a whole list of demands, all aimed at one single goal: letting you see what things actually cost before you get the bill. The thinking is that if you can compare prices and see things like claim denial rates, you'll be empowered to shop around for better value. But here's the catch. According to policy experts, many of these ideas aren't really new. Some are already part of the Affordable Care Act, and others were actually put into place as rules during the first Trump administration. And this quote from a healthcare dive analysis really gets to the core of the problem. Even with the rules that already exist, a lot of hospitals and insurers just don't comply. And there's very little evidence that simply posting a price list has actually done anything to lower costs. So, when you put all these pieces together, what is the big picture critique from policy analysts? Is this a plan, or is it a set of talking points? Well, one of the sharpest critiques makes this really stark comparison. On one hand, you have the Affordable Care Act, which is a massive, detailed law with thousands of pages of rules. On the other, the Great Healthcare Plan is described as a list of goals and talking points, but it's lacking the actual legislative language or roadmap to turn it into policy. And what about the cost? The Committee for a Responsible Federal Budget ran some rough numbers. And while some of these measures could save about $50 billion over a decade, the new direct payments could add up to $350 billion in new spending. The final price tag really hinges on all those details that haven't been specified.
And finally, critics are pointing not just to what's in the plan, but what's missing. For a proposal with such a sweeping title, it's silent on some of the biggest challenges in American healthcare: the employer-sponsored market where most of us get our insurance, the future of Medicare, and the crisis of rural hospital closures, just to name a few.
And that leaves us with the central question, doesn't it? The plan has ambitious goals and some very big ideas, but the real test is turning that framework of talking points into a detailed, workable policy that can survive the immense complexity of the U.S. healthcare system. That is the challenge that lies ahead.